All right.
527.
527, Senate Bill 527.
Thank you, members. I don't intend to ask for a vote on this today. I know that it's been filed this week. I kind of gave the highlights to the Senate about the bill, but
we'll let the other members see how they feel about it after they hear the bill.
Okay, but anyway, folks, this is our reauthorization of the Medicaid waiver program through our home. I'll just go through this very, very succinctly. I think we've made a few changes, but the big highlights of the bill are that it will capture the pharmacy rebates, will be captured and come back to the state. And then it adjusts the medical loss ratio from a current 80-20 to a 90-10. And it adds also that a federally qualified health center can also qualify for a Carrying Bridge organization. Carrying Bridge organization is a terminology we utilize for the maternal homes. We have not had uptake on the Success Home or the Rural Home. They're looking at combining those into one, but we've kept all of that language in the bill, specifically for the maternal homes and the other Life 360 homes. So that is what that is. The definitions that are included on page 5, medical loss ratio is a definition that's new, that's included. Pharmacy rebate definitions on 19 through 28 are directly taken from the Pharmacy Benefit Managers Licensing Act. We are allowing cost sharing. The cost share amount, which is also paid by the state of Arkansas, will be that will also be included in what we consider for the premium tax, as well as for any medical loss ratio. And then on page 7, what it does is that it just sets up the system for tracking the pharmacy rebates in those two sections there. And then on page 8, as you know, the governor announced and has already submitted a waiver to incorporate work and volunteer service into this program. And so this language on page 8 is reflective of what they've actually already done, but members felt that they wanted to put that language in the bill as well. So that's in there. On that, again, making sure that we comply with all federal and state requirements. There are the level of exemptions there. There can be volunteer work as well as work. It could also be a combination of those things. And those exceptions are consistent with what I think Arkansas has done in the past, but also trying to align with what changes are being made at the federal level. And then it changes dates, and this would be for another 5 years. It does have the trigger information, and it continues, and all of the different types of accountability and quality measures are still part of this. We still have the quality measure reviews panels that are meeting to further develop the program.
All right.
So I just wanted to present this information in this bill. We have a whole week of spring break for people to read it and digest it and understand it. And that's why I wanted to talk about it today and present it, knowing that it can't come to the Senate floor until, at least 10 days from now.
All right. Senator Flowers, do you got a question?
Thank you, Senator Irvin. I just briefly glanced at yesterday,
Yes, ma'am.
but and even though you have what medical loss ratio means, I need that broken down.
Yes, ma'am.
To understand it, how it works, and then the pharmacy rebates. That is. I'd like to know, how does that work? Are we talking the department getting pharmaceutical companies to give a rebate, and then how does it work?
So I'm going to tackle the medical loss ratio part, but then I'm going to ask Senator Boyd to talk about the pharmacy rebate part,
Okay.
because I think he's very knowledgeable, much more knowledgeable about that than me. The medical loss ratio just means that you have to basically show that of the money that we're giving you, that 90% is spent on actual health care through claims data.
So this is for Medicaid patients.
Yes, ma'am.
So they get real dollars in their hands?
No. To the providers.
Oh, okay.
Yeah.
So the provider gets money.
And then they also get a portion of the funds that we give to the payors, to the insurance companies. They keep a portion of that for the administration of those of processing those claims. So that's the 10% part. The medical part is saying that is the amount of money that has to be spent on the medical treatment, health care that's paid out on behalf of the recipient. And yeah, and
Well, that would be, because you have 90% toward the back. I saw that figure, and I haven't really thought about public health in a while, and so
Yeah.
I'm just not. This on page 9, it mentions maintain a medical loss ratio of at least 90%. It used to be 80%, I guess.
Mm-hmm. Right.
So the provider has to spend 90%.
The payer.
The payer.
Yes, that's the percentage of the
so
premium.
That's the insurance company.
Yeah, that's the percentage of the premium income that the health insurers spend on medical care and quality improvement, as opposed to administration, marketing, and if applicable, any profit.
Do you think their fees are going to go up as a result of this?
I think that they can provide probably better testimony than I can about that. And I think
what would you think?
Well, I think that what we did was we looked at medical loss ratio at the federal level at different levels of where health insurance is. They looked at, I'd say Department of Human Services could probably answer this better as well, but looked at where other states were in MLR, what's allowed under the federal guidelines for the different components of I would say management of Medicaid. There's a variation and a range that goes anywhere from 80 to 93%, I think. So I think they just kind of try to take into consideration all those different factors when looking at the medical loss ratio.
What is the patient's portion?
So DHS would probably better answer that question as well. I believe so, yes. No?
And I guess my last
yes,
question.
they are. Yes, cost sharing component is something, that's why we pay the cost sharing component of it, which
state.
is, so I think, I don't want to say something.
I'll wait till they answer that. But the other question about the work requirement and the exceptions or the exemptions. So you put this language in there on page 8 as you anticipate the waiver being approved by CMS?
Yes, ma'am.
And so if it's not, we're still stuck with this? Or they would have to approve it, wouldn't they, for us to even
Yes, ma'am.
do this?
Yes, ma'am.
So are we putting the cart before the horse?
I'll let them come and answer those questions if that's okay, because I think those are good questions, but I want to make sure you get good information.
Good morning, Janet Mann, DHS.
Did you get the question? I hope you did.
Yes, ma'am. I think you asked me several. I think I'll start with the work requirement question and work backwards. And if I miss one, please correct me. The language for the work requirement is there, and we have gone through public comment. We're in the process of submitting it to CMS either, I think, Friday or Monday. And our intent is to negotiate and have a work requirement effective with the waiver. So I think this language just supports us doing that work requirement.
If the waiver is not granted, then how does this, what happens with this language?
I think if the waiver is not granted or CMS doesn't approve it, then I think it would be DHS's responsibility to come back with amendments and additional items for the work requirement and continue to try to get it approved.
Because if you don't get approval, you can't do this. The state can't do this.
We can, if we don't have CMS approval, we cannot do a work requirement.
Okay.
Yes, ma'am.
That's what I thought. That's why I said, you know, are we putting the cart before the horse?
No, ma'am. I think this language supports the intent of us submitting, and this is a reauthorization. I think there's current work requirement language in the actual statute now, and this just continues that so that we can continue to try to have a work requirement.
So what's in the statute now is not, you can't execute it.
That I believe so.
Okay. You can't require somebody to work now to get.
No, ma'am.
Okay.
No, ma'am.
It's just there.
It's there, and so we submitting to CMS and trying to have a work requirement, we would have to have that approval.
Mm-hmm. And so the other thing I asked about was the rebates, and how does that work?
So I will start, and I think Senator Boyd may have to help me. So rebates.
So I was going to, I'm not trying to cut you off. I was going to have the Pharmacists Association, with Senator Irvin's permission, explain how the rebate situation works, if you're okay with that.
I had the other question about the premium and the medical loss ratio.
Yes, ma'am.
Just kind of wanting to understand and trying to, you know, visualize what is this? How does this?
It is yes, ma'am. The medical loss ratio is a requirement that we set a percentage of the premium that we pay to the carriers. They must spend X percentage on medical claims. So it does range between 80 and 93% across the country. And so we've set in this proposed legislation is setting it at 90%, which would charge the carriers to spend 90% of what they are paid as the premium on medical claims for the beneficiaries.
And I remember several years ago when I was closer to Public Health Committee, the state would get a refund or money back from the insurance carrier if they had not expended the percentage of monies for medical care. Is that right? Is that what this
correct.
is about?
Yes, ma'am, that is correct. So Our Home program is matched at 90% federal money, 10% state money. So at the end of the year and after closeout of claims, they are reconciled. And then if the medical loss ratio is not matched, the carriers will refund that or rebate that money. Then the state has the responsibility to rebate that money at a 90-10 split to the federal government and 10% back to the state.
Of the refunded money.
Yes, ma'am, of the refunded money.
And so, am I supposed to understand that we've been getting quite a bit of refund back, and that's why we're increasing it to 90?
No, ma'am.
Or just the opposite?
No, ma'am, we have gotten rebates in previous years. I would have to go back and look at how that split happens, because we really don't get it. I think it's almost 18 months later. I think the carriers can correct me if I get that number wrong. They have a time period for the claims to be filed and then reconciled. So we've not gotten a rebate every year. It depends on the claims and what happens with that population.
And then why would we we increase it by 10%.
We're wanting them to spend more of the money on medical claims. We're wanting them to spend as much money as possible on medical claims.
I guess because they haven't been giving us money back, because they've had that 80% medical loss ratio. Does that make sense? I mean, I'm just trying to understand why would we increase it except for some benefit to the state?
Well, I think the benefits to the beneficiaries. I'm wanting more, we are wanting more spent on medical claims, so we're increasing that percentage for the carriers to spend.
But if they don't spend,
If they don't,
it comes back into the state's coffer.
the state and the federal, yes.
So that's what I'm saying. I'll let it go, but I just can't really grasp that.
Thank you,
What-
Senator.
Go ahead.
Senator McKee, you got a question?
Thank you, Mr. Chair. I think I missed a little bit of the discussion on the work requirement. I apologize about that. But can you explain, obviously, we have to get a waiver for that to go into effect, but is there a way within this we couldn't just create a work requirement so that if they give us a waiver, we handle that, or is this a trigger? Can you explain?
Yes, so we have to apply for a waiver to add the work requirement into this program, but this whole program is a waiver. So the whole program is under a Section 1115 waiver from the federal law. So that Section 1115 waiver basically dictates the parameters around what we can do in this program. Because CMS, CMS is Center for Medical Services, Medicaid and Medicare Services. But the federal government funds a portion of this program. So it's a 90-10. So 90% is paid by the federal government, 10% of the program is paid by the state government. So when they are paying 90%, they have a lot of say in how we structure this program. One of those is budget neutrality, which I think is very important, and that's why we utilize the 1115 waiver and that language. And so, yes, CMS would have to approve this waiver as we have presented it.
Follow up?
Yes.
So this is a waiver,
Yes.
and what actually creates the work requirement?
Again, submittal to CMS for approval. So we actually have existing language that we never struck about the work requirement.
Okay.
We just wanted to make sure it was included here in this waiver request as well.
Okay. Thank you.
Senator Johnson?
Thank you, Mr. Chairman. And Senator Irvin, Ms. Mann, I would like to hear both of your comments on this. I'm not trying to compare and contrast it. I do want to compare and contrast something, though. First, could you compare and contrast the waiver that we sought previously that was denied under the Biden administration with this particular one and how they differ?
Yes, sir. So we had a waiver that was struck down by the court in 19. It had some very prescriptive language that we had requested, and I'm going from memory, so
It's okay.
I may
trust
need to.
you. We got time, as Senator said, we're not going to vote on it today. You can clarify later.
The comparison document is sitting on my desk. So we had.
You can email those to me. Thank you,
I can
Jen.
do that. So it was very prescriptive, and it was struck down because it was a condition of eligibility in the previous waiver. That was what was struck down. In this waiver, we are attempting to make it an individualized approach with the beneficiaries, and we are trying to leave some things open-ended to be able to negotiate with CMS to have some of our descriptions through the terms and conditions. That is, and we are not making it a condition of eligibility. We are making it, if you do not comply, you will have your benefits suspended, which is terminology and practice we use with other individuals when they are no longer currently eligible but could be again. So that's the biggest difference, is condition of eligibility versus suspension. But I can get you the comparison
And
document.
I would appreciate that. And quick follow-up, Mr. Chairman. I'm okay with everything in the listed things on page 8. The only thing I'm not 100% cool with is the volunteer hours. And I like volunteer hours. I think great people do that. You know, we've got it in the LEARNS Act and all this, but it's a little squishy as far as, you know, if someone is working, you know, they can show you their check stub, or you get a W-2 or whatever, and they qualify. That may meet that requirement. Volunteerism is a little more. Let me just say that it could possibly have a potential for abuse, and I do want to see if there might be some way to tighten that up. And I realize you've got to write something that CMS will approve. I mean, I get that, and I'm not trying to you know, throw a poison pill into this, but on the other hand, the intent, it appears, Senator, is we want people to be off Medicaid and off welfare and standing on their own 2 feet and having a good job and having training to do that good job. And so I just want to make sure we're making progress with that with each beneficiary.
Yeah. I really appreciate the conversation and the question. And let me just say, there are areas in the state, and I've had this conversation with many, where jobs may be plentiful. There are areas in our state, though, where jobs are not plentiful. And that we know that. We have put in, you know, a lot of time and effort in economic development in the areas of the state, particularly the Delta, where there just isn't that job opportunity. So to me, I feel like this is the right approach, but I'll also say, you know, if you look at the claims data and the recipients and the people that have come into this program and who have left the program, there are success stories, right? And so it's so much better when you analyze who is the recipient of the program for you to be able to make better policy decisions. And that's what we've been able to do in this program. And it's because of the work that we did in the original Our Home that we passed 2 years ago, 3 years? I don't know. But we have met periodically, quarterly, I think. Was it quarterly? Yeah, quarterly. We've met quarterly, and we've had excellent discussions around this program. We've looked at the claims data, we've looked at like the spend, and we've identified the people that are actually on this program and how long they've stayed on the program. It's not very long. So to me, I think this is a great component of the bill. It really ties back to that rural and success home, which is if you feel a lot more successful if you're actually spending your time, you know, developing a career, getting your education, volunteering for something, working. It really just gives you a lot of self-worth and value. And I think that was the whole idea behind a rural home and a success home. And so the work requirement kind of fits into that whole idea. I also want to say, once somebody volunteers sometimes, it really can spark something in them that then creates a whole entrepreneurial spirit. At the Black Caucus, Senator Murdoch had somebody who came and spoke, and he was incredible. And he talked about entrepreneurialism, and he talked about entrepreneurship, and he talked about how so many times it actually starts by somebody just volunteering in a capacity that leads them into an idea to create their own business. And so I think there's so much value that we're kind of skipping over, but that's really important with this component. And to your point, Senator Johnson, we do have to write it in such a way that the federal government will approve it. And so, you know, we want to make sure that the eligibility language is very, very clear and distinct, as Ms. Mann stated. There are very clear things that we cannot mess with when it comes to eligibility of Medicaid. So, and it's based solely on your percentage of income.
Well, if I could, I just want to end by saying that I'm very supportive of the work you're doing on this, and we're going the right direction. You've heard the saying that, public assistance should be a safety net and not a hammock. Mm-hmm. And I want to make sure that if someone is, for lack of a better word, flouting the work requirement, that they can be removed. And if y'all can provide me, and again, you can send it to me, information that would make that
suspended.
More clear.
Yes, sir, we will.
Thank you, Ms.
Senator Flowers.
Senator.
In respect to his comments about welfare and stuff, individuals, we got plenty of corporations that are considered persons that are accepting welfare. And I just want that to be on the record when you talk about people's health care and whether that's something we shouldn't provide people that need it, can't afford it. When we give so much to corporations, I don't know if you even consider that, but you should.
Is it a question or?
Mr. Chair,
That was my comment. That's all it was.
So,
do we want pharmacy rebate information? Yes. Okay.
Senator Johnson, we're not going to be done with discussion, but for his schedule, the Pharmacists Association, I've asked them to come to the table because this is a complex issue, and they're not here to speak for or against this bill, but to help provide expert testimony on something that's complex. So with that, John Vinson, you're recognized. Introduce yourself for the record.
Thank you, Mr. Chair, members of the committee, bill sponsor, and bill sponsors. I'm John Vinson, CEO of the Arkansas Pharmacists Association, and on Senate Bill 527, let's see what page?
5.
Page 5, and then
I think it's also
my glasses on. Or on the copy I have, I was looking at, I think, line 7. Yeah, there's several places it's referenced. But the concept of a rebate for pharmaceutical in the traditional Medicaid program is defined in federal law. And there's a formula, and there's regular rebates and supplemental rebates. And those rebates are discounts off of both brand and generic prescriptions. The larger amount would be on brand prescription drugs because those are more expensive prescriptions and there's deeper discounts on those under the traditional Medicaid system. In the Our Home program with private insurers, those rebates are negotiated outside of that traditional program between a pharmacy benefit manager and the actual manufacturer. And this legislation, the way I understand it, seeks to clarify and bring some transparency to that process for the department to be able to see what that looks like and if those discounts are being used to lower the premiums to their maximum amount in the way they do in the traditional fee-for-service Medicaid program. I would bring to your attention that of the 2 major carriers in the state that currently use that program, one of them uses CVS, one of them uses Express Scripts. There's a couple of examples that have been in the news recently where it's even more complicated than what I just described, that they use an intermediary between the PBM and the manufacturer called a group purchasing organization. And a couple of those are located offshore. One of them is in California. In the state of Illinois, and the U.S. Federal Postal Workers was actually through a similar transparency program actually able to find millions of dollars that wasn't being passed through, and they were able to get that rectified. So I applaud the state to try to do that here in our homes. And I'd be happy to answer questions.
Senator Murdoch.
Thank you, Chair. Mr. Vinson,
Are we still on the same bill we're not going to vote on?
Yeah.
Yes.
Okay. All right. Thank you.
I'm continually frustrated and confused by the PBM existence in these relationships. It seems to convolute, sometimes contradict, and cause issues that are hard to be determined by us, as it comes to us. It's not clear, and it seems to always have, and I hate to be always so, whatever, negative, I guess, about PBMs and that, but nothing seems to be clear, concise, or even fair, and it always ends in something that we have to revisit. And I know that our department is there to be our safeguard in this. At least that's what I hope is still happening. But it doesn't even make sense to me. Part of your conversation made sense. Then when you got to the PBM part, and then the third party part, the other part.
Yeah, the GPO, yes, true.
Why does it have to be so confusing for a simple transaction? And it seems to be because of the PBMs in this world.
I agree. I would say I'm not going to talk about other bills, but there is bigger policy discussion of if there are discounts, should those discounts come directly to the state the way they do in Medicaid versus through an intermediary? This is a good, I think, build upon the transparency that the department has created in the past system to increase the transparency in our home. And I know I've had really good conversations with Janet and with Elizabeth and with Medicaid in the past. So to me, it looks like that's what they're doing in this step, is to make sure that what they believe is happening to lower the price for the state is happening, and ensuring to the best of their ability that those discounts are passed to lower the price of the program.
We're going to discuss it later because we're not going to vote today, but I just wanted to add that. And I'm sure I'll hear from the PBM people, pro PBM, and I love the conversation because it just never seems to make sense.
And I shared the example of Illinois and the U.S. Federal Postal Workers because those are state-funded plans or federal-funded plans that did exactly this. And when they started digging, in fact, the rebates weren't all coming through. They had to actually have a lawsuit because of those findings, and there were settlements. And I hope that's not the case here, but this would bring the transparency. Thank you.